Hi everyone, this is Morgan from the New England QIN-QIO. I'm going to go ahead and mute all participants. As soon as I do this, Rebekah, feel free to start.
Thank you, Morgan, and good afternoon to all participants. We're so happy to have you here, and welcome to this medication safety webinar. We'll be discussing how to cross the medication safety chasm by more effectively using your state's prescription drug monitoring program, and we have a great panel of speakers to help us get there. Before we get started, I'm going to quickly review a few housekeeping items. This call will be recorded, and the recording will be available within just a few business days on our website. Phone lines will be on mute while the speakers are talking, but we'll unmute the lines after the third presentation for questions. And I'll give some instructions on how to ask questions at that time. Although the lines will be muted, we would still like you to actively participate during this session by using the chat function. My colleagues, Morgan and Margie, will be monitoring the chat window and responding to your comments in real time. Don't be shy. We'd love to hear more about your efforts and how we might best support you going forward. And we'd also love to hear your thoughts about what the speakers are saying. So please use that chat function throughout the presentation. We'll start using it right now by seeing who's on the call. So locate that, for most of you, it'll be to the right of your screen, and you can type in your name and your role, your organization, and the state that you come from. While you're doing that, it's important to note that today's speakers have no conflicts of interest to disclose. At the end of this hour, you should be able to describe what information is in the PDMP and why it's important to use it. And you should have a better sense of how others have been able to incorporate use of the PDMP into their own workflow, regardless of setting. I'd now like to introduce our first speaker, Marriott, who will be giving us the state perspective on prescription drug monitoring programs. Dr. Marriott graduated from the Northeastern University with a Doctor of Pharmacy degree in 2004, and after practicing pharmacy in the community setting from 2004 to 2008, he joined the state of Connecticut Department of Consumer Protection in the Drug Control Division. And he worked as a drug control agent until 2016, before he accepted the position of Director of the Drug Control Division. So with that, need to give him presenting capabilities, and we will get started. All right, Rod, I think you should have control of the screen at this point.
Great, thank you, I do. Thank you all for having me today, and hopefully I can provide you with a little bit of perspective on the state of Connecticut and our prescription monitoring program, some of the tools that we have for you. So, our program launched in 2008 as a single-source database of all controlled substance prescriptions Schedule 2 through 5. And what it did is it granted access to prescribers, pharmacists, and law enforcement, and provides currently up to about 3 years of data to all of those different individuals in our system. In 2013, we mandated that all prescribers in possession of a registration, a controlled substance registration, which is a lot like a DEA specific to the state of Connecticut, were required to register with our system. And at the same time, any prescriber who dispensed controlled substances from their practice or facility are required to upload that information, much like a pharmacy already was required to do. In 2013, over the last few years, we've seen a dramatic increase in our usage of the PMP. So obviously from 2013, you can see the numbers there from 190,000 to almost 484,000 practitioner reports have been run. The pharmacist reports are also increasing over time. Our law enforcement reports are actually decreasing, which is kind of interesting. But you can see that we have up to 6.2 million prescriptions in the system in 2015. Hopefully we'll have more data of 2016 soon. So as you see our numbers increase, some of the genesis for that is that in 2015, we had a law that required any prescriber writing a prescription that's greater than a 72-hour supply of a controlled substance, and a requirement for them to look up the patient prior to writing that prescription. But there is a caveat to that in that if the prescription is continuous, they have to look it up once every 90 days. There also is a provision in our law to allow for physicians who may not have had access at the time because of our system or their internet system being down, that they can still write for that supply, that greater than 72-hour supply, without looking them up, but they have to do it within 24 hours of regaining access to the system. So obviously, a law like that is going to increase the numbers of usage of physicians, and it's been doing that effectively, as you can see from 2015. In 2016, we allowed for expansion of the authorized agent. Prior to 2016, the only authorized people to use the system were licensed individuals. The only agent in a doctor's office could be an RN or an LPN, or even a pharmacist if they had a pharmacist. But in 2016, we expanded that to be anybody, because not every physician's office had a licensed person in their facility. We also had to carve out for veterinary facilities, so they don't have to report daily like physicians and pharmacies do. Pharmacies have to report every 24 hours, within 24 hours of filling a prescription, which you'll see below, which started on July 1st of 2016. Whoever prescribing practitioner rates greater than a 72-hour supply, the agent has to look that patient up. But for Schedule 5 controlled substances, we only have to look them up once every year. So recently we have added a couple of features that we think are really going to be valuable for our practitioners. It allows them to maybe get a context on some of the information that's in our system that they're not necessarily seeing. So the first one is what we call a prescriber and dispenser threshold quarterly report, which is currently in our system is down, which for maintenance, we're having a little bit of trouble with the way they're running the algorithm in certain parts of it. But the idea is, people kind of commonly know this as a doctor shopping alert, which means their patient is using 5 or more pharmacies and 5 or more prescriptions from different prescribers within a 90-day period. So when that happens, there's a notification that a physician gets, either solicited or unsolicited. So if that prescriber wrote a prescription for that patient, they may get an alert they're supposed to get an alert after that person hits that threshold report. But if someone were to search that patient, there would be an alert pop up on their screen. The other alert, that alert has been in our system for about 30 days. Currently, we have 2 new ones which have been in for the last 2 weeks, which is a daily active morphine milligram equivalent threshold notification, and that is currently set at greater than 90. And then the last threshold alert is an opioid prescription and a benzodiazepine prescription. These alerts are based on things that we're starting to see come out from CDC and the CDC prescribing guidelines. And we think that they're valuable tools for our prescribers and pharmacists to help them make better clinical decisions and when treating their patients. Excuse me? So anyway, the idea of these reports are basically to kind of allow them to have value to prescribers to make decisions, but not to necessarily make decisions for them. So we're very fortunate in our system to have linkages with at least 25 states, including all of New England. And we are proud to announce that we just had our first linkage with an electronic health record. And there'll be more press release on that probably in the next 24 hours. But one of our local hospitals here has linked it into their Epic electronic health record, which basically will allow our practitioners to have better access and faster access within their health record to just press a button and run this report as opposed to jumping out into our web-based platform. So that's pretty much it for my part of this talk, and I'll be around again for questions. I'll move the ball to Rebekah.
Thank you so much, Rod. That was really interesting. Feeling that Connecticut.
Hey, Rebekah, it's Morgan. I wanted to go ahead and mute everyone one more time because it sounded like we were having some feedback coming in. So I'm going to go ahead and mute everyone, and again, our speakers, you guys will have to press #6 one more time. So bear with me while I mute everyone again.
Okay. Hopefully I'm unmuted.
You are good to go, Rebekah.
Thank you. Thanks for that, Morgan. And thank you very much, Rod. That was really interesting. Connecticut seems very far ahead of the curve in terms of the functionality of the system there. So we'll definitely be more excited to hear more about that at the end when we have time for questions. We're now going to hear from Dr. Poshkus, who will give us the perspective of a physician working in the community and how he's able to use the PDMP. Dr. Michael Poshkus is the Medical Director of Sunderland Community Health Center, which is in West Warwick, Rhode Island. He is board certified in both infectious diseases and internal medicine. And his interests include working with marginalized populations, including those with a history of incarceration, substance use disorder, HIV, and Hep C. So, Mike, I'm going to pass the presenter over to you, and you should be set to go.
All right. Thank you so much, Rebekah, for introducing me and for inviting me to speak today. So as Rebekah had stated, I'm a community health provider in West Warwick. And West Warwick is a federally qualified community health center. The Sunderland is, and we cover 3 sites in Rhode Island, which pretty much covers the whole state. You can see on the map. And West Warwick is the middle dot there. Our mission is to provide, improve the health of our patients and their communities by delivering exceptional health care, removing barriers to that care, and promoting healthy lifestyles. And so I think the mission of the Community Health Center is very important to the providers and to the community that we are, it's important to us to provide excellent health care for all patients in the community, regardless of their ability to pay. This slide shows just sort of an overview of the demographics of our population and how many patients are covered in each site. The West Warwick site, we see about 16,000 patients that we care for. This is a slide that shows some of the services that are available for us. We are primarily a family medicine model clinic where we have nurse practitioners, family medicine physicians, internal medicine physicians, pediatrics. We also have a residency program where the residents have their primary care clinic at our site. And we also offer dental services. The majority of our patients are on Medicaid. Previously, a lot more of them had been uninsured. So our patients are very from the lower socioeconomic demographics, and a lot of them also, especially my panel, have a history of incarceration. So as a result, the prescription monitoring program in Rhode Island, which is very similar to the one in Connecticut that Rod has summarized so nicely, and I'm excited that it may become incorporated into our electronic health record. But as a result of the patients that I specifically see, the prescription monitoring program has been a critical tool in my daily care of patients. So this slide just shows the regulations that have been instituted into Rhode Island that we must document the reviewing of the prescription monitoring program prior to initiating opioid therapy and every 3 months for chronic opioid prescriptions. So this is an additional administrative responsibility for physicians to do the documentation. And then, so that was one reason that we have incorporated the use of the prescription monitoring program into our practice. And then with the CDC guidelines that had come out earlier regarding the drug overdose and prescription guidelines, they really recommend reviewing this. And so identifying the misuse of opiates and the overdose epidemic, a lot of the prescribers in our practice have become medication-assisted treatment prescribers with buprenorphine. Currently in our 3 sites, we have 14 prescribers for buprenorphine, and we have approximately 200 patients. So all the patients who are on controlled substances, including buprenorphine, I typically review the prescription monitoring program for every visit. This just shows from a slide borrowed from the CDC, the epidemic of opiate overdoses, and you can see in particular that all states in New England are involved in this epidemic. So here are some specific slides that I was able to borrow from Dr. Jim McDonald from the Health Department at Rhode Island, and they specifically show how we utilize the prescription monitoring program. This slide shows the information that is required to look up a specific patient. So typically they need at least 2 identifying measures to look at. So the name and the date of birth is usually what is entered into that. And you can also see that we can also compare, run the patient's prescription habits through other local states. So typically I will also check off our neighboring states of Connecticut and Massachusetts to see if patients are filling prescriptions in other states. You have a prescriber-oriented dashboard, and as it was shown in Connecticut, similarly you get specific patient alerts to be notified about. You can also review your recent requests. And then there's a separate section at the bottom that you can see we have delegates. And as part of our workflow, it's very important to utilize the delegates to decrease the burden on the medical providers. But this is a way that we can review who our delegates have been looking up. This specific slide shows a patient request. So when we do review the patient's prescribing habits, we get a list of all the controlled substances that were prescribed to that individual during whatever time frame we choose, and it lists who the prescribers were for them and which pharmacies they utilize. This can be helpful in the discussion when you meet with the patient to discuss that. So typically, whenever I am prescribing any controlled substances or patients who are on buprenorphine, we have them all sign controlled substance agreements notifying them that they can only get prescriptions from us, or we need to be notified if they are getting them from somewhere else. So a lot of information is gained from the prescription monitoring program, specifically regarding the other prescribers, the pharmacies that they're using. And it also will show you if it was either the patient paid for the prescription by cash or if it was billed to the insurance company, and that can bring about some other questions to have a discussion with the patient. This is the format. It can be modified into a PDF and printed out. So sometimes patients where our workflow, if there is some question prescriptions, my medical assistant will print out the PMP in this format that we can review with the patient and discuss some concerns. Another helpful tool that you can see on this is that it does record the morphine equivalent dose per day. And one of the other regulations in from the state of Rhode Island is to document that the morphine daily equivalent dose is noted. So the PMP is another source for that, and that is another very helpful resource. And then periodically, I suggest that all of our providers, and I do this also, we can check our prescriptions for controlled substances by using this. So when I meet with some of the other doctors or nurse practitioners, we'll pull up their list to review, and it gives you a helpful, you can put in the last 3 months and review all the controlled substances that were filled under your DEA number. A few years ago, by utilizing this, I noticed some prescriptions that I wasn't aware of, and we were able to identify that somebody was writing false prescriptions under my DEA number. So I recommend that all prescribers routinely review their use, their prescriptions. So implementing the PMP into the workflow, what we've done, I have, as was pointed out earlier, Rhode Island allows medical prescribers who have a DEA number or controlled substance license that they are able to assign delegates. All of our prescribers are encouraged to have their medical assistants. We typically have a 1-to-1 ratio of medical assistants to be a delegate. And also the nurses that I work most closely with are also my delegates. So if they are fielding phone calls regarding possible lost prescriptions or requiring early refills, they're able to look up in the PMP. So that is, as far as our workflow, that's very helpful to have for the prescriber. And in our pre-visit planning, at the start of every day, we review the patients that we're going to see, and if there are any patients who are on buprenorphine or Suboxone or who are getting controlled substances, the medical assistant will review the PMP, and as I discussed earlier, will print out anything that has discrepancies. Otherwise, it's typically just written in the chief complaint. That's how we communicate in the pre-visit planning. So the PMP helps to confirm that no other prescribers of controlled substances have been filled by the patient, and including in neighboring states, as we had discussed. And it also identifies changes in prescriptions by other prescribers. Sometimes our patients are also seeing psychiatry, and they're prescribing other medications, and so we would be especially concerned about the combination of benzodiazepines and opioids that we may be responsible for. So if they're not necessarily disclosing that, that's something that it can be revealed and discussed with the patients. And then also, as I had mentioned, that we review the PMP with prescribers periodically in their evaluations. So it's really been a very valuable tool in my practice personally. I found it very helpful opening discussions sometimes for patients who may have an opioid use disorder that we hadn't previously recognized, and allowing that discussion to go forward to discuss other options as far as overdose prevention, prescribing of naloxone, or also referral to additional substance use counseling. So I think that the PMP hopefully will be continue to be used by other places. I'm excited for the integration of it into our electronic health record, and I think that that will be a very valuable tool going forward, and will likely become the standard of care in most practices. So with that, I will pass the direction back over to Rebekah. Thank you.
Thank you so much, Mike. That was really informative, and hopefully for our participants as well. Our third speaker with a pharmacist perspective is Madeleine. Madeleine is a pharmacist at Westview Nursing and Rehab at West Warwick as well. Following her graduation from the Mass College of Pharmacy in 2015, she completed a community pharmacy residency with the University of Rhode Island in Rite Aid Pharmacy. She's worked with patients in various settings, including home health care, nursing homes, and retail pharmacy. Her particular interest is transitions of care and the role that pharmacists have in optimizing medication therapy to improve outcomes, reduce readmissions, and improve overall quality of life. So with that, I'm going to give her ability to advance the slides. And Madeleine, you should be all set.
Thank you, Rebekah. So like Connecticut, there is a driving need for pharmacists to help address medication safety in Rhode Island, and the PDMP can help. The graph on the left depicts an increasing trend of monthly accidental drug-related overdose since 2013. Although utilization of PDMP by prescribers in Rhode Island has increased within the last 2 years, as seen on the graph on the right, the number of PDMP reports that are actually run pales in comparison to the number of Schedule II prescriptions written. My experience using the PDMP report includes 3 unique practice settings: community pharmacy, skilled nursing facility, and home health. As a community pharmacist, the PDMP has proven to be the most effective intervention to identify prescription drug abuse or misuse. Ideally, PDMP should be accessed for every narcotic prescription that comes into the pharmacy, especially if written for a Schedule II medication. Clinical judgment must also be utilized to recognize certain triggers prompting further analysis of PDMP. So for me, this may include if the patient is new to the pharmacy, bringing in new prescriptions, or if the patient is paying in cash. Each prescription is always analyzed for clinical appropriateness by the pharmacist. So this means, does the medication at the quantity prescribed make sense? Depending on the company that the pharmacist works for, the computer system may also trigger the pharmacist to look at PDMP during the dispensing process. So as you can see, there are multiple opportunities to utilize PDMP in workflow, but time is often a barrier for most community pharmacists. Although pharmacists must make the final clinical decision to dispense the medication to the patient, there are certain tasks that may be delegated to pharmacy technicians and pharmacy interns to reduce burden and also to help identify triggers. So the technician entering the prescriptions into the computer can help identify if the patient is new to the pharmacy or if the patient has gotten these prescriptions filled before. And if they had gotten the prescription filled at the pharmacy before, when was the last fill date? Is the patient trying to refill the prescription too early? PDMP also allows pharmacy technicians to register as a delegate for pharmacists. This is an opportunity the pharmacist may choose to utilize, and this depends on company policy and state policy as well. The next step is accessing the PDMP report, which will be discussed in a following slide. Lastly, follow-up is critical in the success of PDMP utilization. If a positive PDMP report is identified, the prescriber will be contacted by the pharmacist so that they are aware of what's going on, and the patient will also need to be contacted as well. Although the settings differ in a skilled nursing facility and home health care setting, the workflow process remains the same for me. Triggers may be identified at different points during the medication reconciliation process, prompting PDMP report accessing. On the other hand, if I am performing a home visit for a patient, another trigger for me would be finding multiple prescription bottles of different narcotics written by different prescribers. So workflow management differs slightly than in the community pharmacy setting, but PDMP is still integrated. Assessment of the PDMP report will be, again, discussed in the next slide, and follow-up again will need to be provided to the prescriber and to the patient. So when assessing each PDMP report, there are certain red flags I will look for. These include patients that utilize multiple prescribers and multiple pharmacies, patients that are consistently refilling early. If a patient has multiple addresses or date of birth on the PDMP, this is another red flag. If the patient has no prescriptions on PDMP, this again might be something that I take another closer look at. And if the patient is paying in cash. There is value for pharmacists to utilize PDMP regardless of the pharmacy setting they work in. In the community pharmacy, pharmacists are often the last healthcare professionals patients interact with following the prescription of opioid medications. Pharmacists can also recommend Narcan when appropriate, since the PDMP reports will report the morphine milligram equivalent as mentioned before. If the pharmacy does not have their own protocol for dispensing Narcan, then pharmacists can contact the prescriber for prescription to dispense. In the skilled nursing facility, pharmacists can inform the prescriber about to residents' filling history and other narcotics that they may be taking that the prescriber doesn't know about. And again, in the home health setting, pharmacists can identify potential red flags that are found in the home. Lastly, improving the effective use of prescription drug monitoring program, PDMP, can be a key element strategy for reducing prescription drug abuse. Pharmacists utilizing PDMP can assist in detecting and intervening to decrease misuse and diversion of controlled substances. Clinical judgment must be used to identify patients with inadequate or inappropriate pain control. All members of the pharmacy team can be utilized. There are certain tasks that can be delegated to other pharmacy technicians and pharmacy interns that will be valuable to help the pharmacist. And lastly, communication between pharmacists and prescribers is critical to address unsafe medication use. And with that, I will turn the presentation back to Rebekah.
Thank you so much, Madeleine. We'd like to spend the remaining time taking your questions for the panelists. We'll be taking questions on the call-in line as well as through the chat box in the WebEx itself. To unmute your line to ask a question, you'll need to press #6. And then please make sure to remute the line after you've asked your question so we can minimize background noise for the other participants. Morgan and Margie are checking the chat section now, and I want to ask them, are there any questions that have come through chat that we could take first?
There's nothing at this time, Rebekah.
All right, well, maybe while folks are figuring out how to unmute your lines, I could start us off. I have a question for Rod, and I noticed on one of your slides that medical marijuana is in the database in Connecticut, and I'm pretty sure we don't have that availability here in Rhode Island. I'm wondering what prompted that decision and how the doctors feel that's been a helpful thing to have.
So thank you. Yes, medical marijuana is in our system, and the reason why it's there is because we reclassified it to Schedule 2. And for us, that did two things. It allowed a place for physicians to find out what people were using in our system, and we hope actually to get some more information from that, since people have showed interest in seeing if there's a reduction in opioid use based on use of medical marijuana. And it also allows our law enforcement to see cards for our patients to allow them the appropriate protections that we have.
Thanks, Roz. That's really interesting. I'm going to pause, and it looks like we have a message here through chat. It says, how does the program affect hospice patients who are obtaining their medications for symptom management? Rod, I think this is another good question for you.
Well, so the hospice patients, depending on what kind of setting they're in, they may or may not have the prescriptions uploaded into PDMP. But what that should be is a tool for the physician to just maybe get a baseline of where they are, or the prescriber to get a baseline of where they are in their treatment already, and just to make sure there's no other abuses going on, and to have a good conversation with the patient about what is going on. Maybe they're not adequately treating the issues that they're having.
It sounds like it wouldn't prevent folks from getting the medications they needed for folks who have a serious illness or at the end of life.
It shouldn't. And the hardest part about a PMP system from our kind of my standpoint as a regulator is that I don't want it to be used to deny appropriate patient care. And I don't want people, I worry that people are going to take it and make things out of it that maybe aren't there. So our alerts and our features that we have in it are tools to guide them into an appropriate clinical decision, but not the end-all be-all. I recently referred to it kind of like a lab report. I had a lab report recently that showed I had high cholesterol, but based on my cholesterol levels, my physician chose not to treat me with a medication. It's just like this. Based on the levels here, you can choose to do something about the opioids or not.
That sounds very reasonable. We have another question through chat. Ask if prescribers can list a patient or somehow flag a patient in the PMP that they feel is at high risk or shouldn't get more controlled substances. And Mike, why don't I turn that to you? Have you seen functionality like that in the Rhode Island PDMP? Have you been able to flag someone or create an alert in the system itself that shows you've had an issue or there's been a violation of an agreement or something along those lines?
That's a very good question. And yes, there is a means through the prescription monitoring program to alert the other prescribers regarding concerns for a specific patient. So typically the way that it happens is that you do submit a concern. It's reviewed by the health department before it's shared on the PMP. So there's still a vetting process of that information. You can't just put something out there that's shared with everyone. So before it's publicly shared on the prescription monitoring program, it is reviewed. And then, as I had shown in one of the slides, that there is a section for patient alerts, and that will show up that for perhaps one of your patients that you've prescribed a medication for has been getting them from other providers. So that's something that I usually will review and look at and have a discussion with the patient. Sometimes it may be, I'm fully aware of that. It's one of my colleagues who was covering for me while I was away or something like that. Or some other times it could be signs of misuse of the opioids. And so that comes to the attention. But so the PDMP is helpful on a way that you can get information regarding the patient, and you can also notify them regarding any concerns behavior. So previous I gave the example of where we had identified prescriptions that were falsely written under my DA, and that's how I reported them.
That's great, Mike. Thank you. And can we assume that Connecticut has a similar functionality, Rod?
Unfortunately, not at this time. So when we used to have it in our old system, when we moved over to the new system, which appears to be the same as Rhode Island's using, we lost that feature. So the vendor has said that they're working on it. We hope to have it this year restored. We use that alert to alert fraudulent prescriptions of various different things. It was a very, very valuable tool, and we were sad that it wasn't included in this software package. But I'm actually may have to reach out to Michael and see what it looks like. I'm very interested in getting it back.
Great. Thank you. I'm going to pause and see if folks on the phone want to ask a question.
Again, it is #6 to unmute your line.
Rebekah, I see a question in my chat. I don't know if you want me to bring it up. It's from Francis.
Yeah.
Okay, the question is, if the dispenser gets a clinical notification that the patient has met their threshold, how is this resolved in the case of a nursing home patient who needs his or her pain medication? And the threshold reports are just an alert of that this person has hit a number. It doesn't mean that they can't go above or they can't go below. It's just a notification that it puts a patient at a higher risk for overdoses, kind of shown in some of the research as evaluated by the CDC guidelines. But really, there's nothing in there that says they can't prescribe over a 90 MME, and there's nothing that says that you can't prescribe a benzodiazepine and a opioid. But when you start to do those things, you should pay more attention to the patient in a different way and consider overdose as more of a possibility. And then maybe you should consider writing something like a prescription for naloxone. In Connecticut, a pharmacist can write a prescription for naloxone as well. And so maybe it's just kind of, I'm hopeful that those alerts spark a new conversation with the patient and prescribers and pharmacists to help make sure that you don't have any unnecessary overdoses, especially in patients who just seem to decompensate on their normal doses, but now have a means to change that conversation a little bit.
Thank you. Through the chat function we have, can home health agencies call a patient's pharmacy to have them look this information up? And Madeleine, why don't you take that question?
Absolutely. So if a nurse identifies one of their patients has, again, multiple bottles of opioids at home and are concerned about the potential for overdose, they can call the pharmacy that the patient has gotten this prescription filled at and just alert the pharmacist to check PDMP to see what's going on because you are concerned about what's going on in the home setting. So absolutely.
Thank you, Madeleine. Another question for you is how much of an uptake do you think there's been among home health agencies to use this resource? Because it sounds like they wouldn't necessarily have direct access themselves unless they were a pharmacist.
Exactly. I think that is a barrier that we are trying to work across because, it is the pharmacist, usually myself or consultant pharmacist, that will look at the PDMP report. However, I've heard, and correct me if I'm wrong, that prescribers can also delegate nurses at their nursing home setting to be able to look at PDMP as well. So there's opportunities for different practitioners in the nursing home to look at PDMP. It's just implementing it into workflow and thinking about if we should be triggering this patient to look into PDMP or not.
Thank you. We have a question on the chat box asking why the PDMP does not include Suboxone or methadone, other than methadone, which should be prescribed for pain. I know that Mike had noticed this as an oversight as well. I'm wondering if Rod might be able to speak on this for Connecticut.
Sure. So actually, there's a couple of different things in the way this affects our system. Connecticut allows Suboxone. Any prescription dispensed in a community pharmacy. The carve-out is really methadone and the methadone treatment program. And there's specific law in Connecticut, and it kind of mirrors a law that's being used federally to prevent access to this information. And we continually hear that that's a problem. I would really prefer to see methadone in there. I think it's unfair to ask our physicians to get a partial picture. But at this point, we have a specific law in Connecticut that would prevent us from putting methadone used for that purpose in our system.
Rod, does that relate to the 42 CFR Part 2 regulations that protect patients' privacy when they're receiving treatment for substance abuse?
Yes, I believe that's the one that they use. And then, like I said, Connecticut, I think, also added their own law a few years back.
And Mike, are you able to see methadone or Suboxone in the Rhode Island PDMPs?
Yes, buprenorphine and Suboxone is included in the PDMP. Methadone prescribed by methadone treatment centers is not. So the expectation is that the methadone clinic reviews the PDMP to see if the patient is getting any additional opiates or other controlled substances that are prescribed. And so in addition, part of our treatment plan is to check periodic urine tox screens. So if someone is getting methadone through a methadone clinic and also is being prescribed buprenorphine from me, it will come to a discussion when we check the urine tox screens. So I agree. I think that it would be helpful and get a better complete picture if methadone from methadone treatment centers was included in the PDMP, but in the meantime, we're still able to work with that, and Suboxone is listed on the PMP.
Great, thank you. I'm going to pause here and see if folks on the line after pressing #6 have any questions that they want to ask directly. Okay, we have another question through the chat box. Someone asked that around care transitions, Has there been discussion about how the staff at home health agencies are using your service, how they can be delegates? Generally, there's not a, physician medical director necessarily who they could be delegates under. There's not a prescriber that they could be delegates under, so they're in a bit of a different situation than the nursing home nurses and the nurses in the offices. So maybe Rod from Connecticut to speak about the regulatory environment there and whether or not there might be an opening to get those folks hooked in.
Yeah, I think a lot of I recently had a pharmacist approach us on that topic, and because there was a medical director in the program with the VNA, we allowed them, the pharmacist, to be a delegate, and technically any of the nurses could be also. But the key to all of that is that this data is protected from HIPAA and all these other things, and it needs to be used in the right context, and there needs to be controls on it if we want to maintain it. And I wouldn't be necessarily against it. I just don't think that we have a great mechanism always for all those things, and we have all these different places to reconcile these medications. It's no one has posed that before, but I've only been doing this for 8 months.
It sounds like there's a need there. And to ask a question to build on that, for Madeleine, when you do reach out to prescribers, when you do call physicians in the offices to alert them to something you think might be concerning, how is that information received? Or calling either as a pharmacist or a home health care clinician, when you call a physician and bring up a concern, something that you've either noted personally in the home or that you found in the PDMP, how are those concerns managed on the prescriber side?
When I've contacted prescribers regarding concerns I have, whether they be triggers that I've identified or red flags, almost 100% of the time the prescriber is incredibly thankful for me to reach out to them, to let them know about what is going on, because it is their prescriptions as well, their license that the prescriptions are getting filled under. So they are very, very thankful that there is someone else that is looking in the homes or doing a med rec and contacting them. Most recently, I had noticed that one of the patients I've seen had a prescription for opioids and a benzo and a muscle relaxant. So I contacted the prescriber to talk about naloxone and then also discuss PDMP, high risk for potential overdose with him, and he was incredibly thankful that the pharmacist is involved as well in looking at the medications in that way and contacting him to let him know about what is going on outside of the office.
So it sounds like any of the nurses or pharmacists on the phone that do need to reach out to prescribers should have no fear of doing so, that they will be met with gratitude for the most part.
Exactly, especially since now opioid overdose, the use is such a huge national concern.
Right. We have a couple new questions on Fox. Yes, please.
I just wanted to add to that. I agree that the phone calls that I've received from pharmacists regarding concerns on prescriptions, I have always been very appreciative of them, and having the dialogue, I really consider us sort of a team on this, and I know that a lot of the times the patients are presenting to us in crisis. They're also presenting to the pharmacist in crisis, often either in acute pain or in withdrawal symptoms from some of these medications that they are in. So I think seeing the pharmacist and the prescriber as part of the team is really important, and the PMP helps with that communication to make sure everyone's on the same page. And the PMP also sometimes has errors too. This is data entry. So if there's something that is questionable, I will call the pharmacy and say, well, the patient has a prescription and yet it's not reported to the PMP. So you can find out, our system is down. So I think communication between everybody is very important, and I look at it as helpful.
Thank you.
There's another important part of that data issue too, just while we're talking about that, is that really any PMP data should be verified in some way, shape, or form, because it is, again, it's based on an upload from a pharmacy. And just the other day, I got a call from a doctor concerned about a prescription that was fraudulent. And it turns out when we contacted the pharmacy, they just picked the wrong doctor. So there are issues in there, and that same issue could prompt a 5 and 5 report, a doctor shopping alert report, because the pharmacy accidentally chose the wrong prescriber. So it's really important when you take this as a tool, and if you're going to make a decision, you get more educated on it. That you take that extra step to call the pharmacy or call the prescriber and make a determination that the information you're seeing is accurate.
That's a great point. We've definitely had errors within the Rhode Island PMP akin to those as well. We have a bunch of new questions on chat. I'll just point out a comment that someone made here that if you do see someone in urgent care and the patient isn't being necessarily upfront about their methadone use, the frustration around not being able to access methadone from methadone clinics and how frustrating that is. The question following is, I think, directed to Mike, and it's whether or not, how do you, when you have information from the PDMP, how do you get it into the EHR? Do you print it out and scan it in? What in the EHR kind of helps with the workflow, and how do you document that in the EHR when you have a report?
That's a great question, and right now it's a bit cumbersome, so I am looking forward to the integration with the PMP with our EHR. Currently, our workflow is, as I discussed previously, the the medical assistant will document that the PMP was reviewed and consistent with previous prescriptions. They'll just document that in the note. If there is something that is concerning or may change management, then I would typically document that in the note, and sometimes I'll scan that into their records. But typically it is not incorporated into the electronic health record. We do have a sort of a spreadsheet that is where we record the morphine equivalent dose, we record pain management assessments, and we record the date that the PMP is checked. So if we were asked about if we are following the regulations, we're able to pull that data from the electronic health record. But as far as actually having a copy of that put into the chart, that's not done. It's physically entered into the notes of saying the PMP was reviewed and is consistent with previous prescriptions.
Thanks, Mike. We have another question through chat wanting to know...
I'd like to add one thing quickly to that, just from a regulatory perspective. I've asked to make sure that our vendor is fully auditable, and right now they are fully auditable on what our prescribers and pharmacists are using as a tool. But as a regulator, I don't want to necessarily be falsely accusing people of not using it. I've also said that in the interface, we need access both from the electronic health record of the facility and PMP to know who's run it, so that, again, I don't falsely accuse people and people get credit for the effort that they put into this. It's really important that if we're going to do these things and we're going to hold people to a standard, that there has to be an auditable trail for protection of our physicians and healthcare workers.
Madeleine, how do you generally record when you access the PDMP? How does that make it into the record of the patients that you're caring for?
There is, so most of the documentation on the pharmacy side is going to be related to the actual prescription. So every time a prescription comes in and the PDMP report is checked, I'll note on the prescription that the PDMP report is checked. I know some pharmacists actually print out the PDMP report to attach it to the prescription as well, so there's some documentation on there. As well as if we contacted the prescriber to discuss the PDMP report. In the nursing home, if I do access PDMP report, I'll note it in the chart and say that I had discussed this with the prescriber as well. So there's always a documentation trail.
Great, thank you. Also on chat, I think we have time for about 2 more questions. Also on chat, someone wanted to know if patients are ever referred to pain clinics as a result of these findings. Mike, maybe you would want to take that one.
Yes, definitely. So when there is information from the PMP that I wasn't aware of, for example, that they're getting pain medications from other prescribers, then the conversation changes to what is going on. Is this misuse? Is this related to dependence or addiction, or is it to undertreated pain management? And so the regulations require in Rhode Island for above a certain morphine equivalent dose that we have to document that it was considered to refer to a pain management specialist. Doesn't necessarily have to be referred, but if you do not refer them, for example, the patient's been stable on this dose for many years, you need to document the reason for that. So referrals to pain specialists as a result of the PMP are often because of very high morphine equivalent doses, or as a result of realizing that they're getting multiple pain medications from multiple people and addressing that and identifying that the pain is undertreated, or identifying that they have opioid use disorder and then sort of changing the conversation. So the PMP is helpful with that.
Great. Thank you so much. And unfortunately, that's going to be our last question. Rod, if you could look at the chat box, there's a question there that I think you could probably answer, and it looks like you just did. So we are in sync. So thank you very much for that. We're going to enter the wrap-up phase here. I wanted to let you all know that we have a number of other related programs coming up in the spring and summer, including sessions on antibiotic stewardship, anticoagulation in the clinic, and improving care transitions for diabetics, which may be of interest to y'all as well. So more information on these and on many other med safety programs that we work on is on our website. For folks who are claiming continuing ed credits for pharmacists listening in the ACTE code, it's opioid. And I wanted to let you know that if you have any comments or questions based on what you've seen today, or if this has prompted other issues that you want to take on, I've included the contact information for our state leads for medication safety, and they'd be happy to continue that discussion with you as much as you would like. So with that, I'm going to thank our presenters and our participants for all their great questions and turn it over to Morgan.
Thank you, Rebekah. I just have a few announcements before we end today's call. As you close out of the webinar, the evaluation will automatically pop up on your computer. If you could please fill that out, we would greatly appreciate it. In there is where you will enter the code to receive your credit. If you don't have time to fill it out right now, or you're sharing a computer with someone else, you will receive an email tomorrow containing the link to the evaluation, and you can complete it then. As Rebekah mentioned at the beginning of the webinar, the PowerPoint presentation is posted on our website, and in that email you receive tomorrow, there will be a link where you can download it. And that site will also include a recording and transcript within the next few business days. As you can see from this last slide, the New England QIN-QIO is now on social media. You can find us on Facebook and LinkedIn, so be sure to check us out and like us. And be on the lookout for emails about our next webinar on March 14th. And thank you again to all of our speakers and everyone for attending. Have a great day.